Oh, so did he not put it?
Hello, everyone, and thank you for joining us for today's Clinical Distance Learning Series webinar. My name is Diana Simon. I'm a Senior Program Officer at the Center for Healthcare Strategies. We're a core partner in the Technical Assistance Network for Children's Behavioral Health, funded by the Substance Abuse and Mental Health Services Administration, SAMHSA, Center for Mental Health Services, Child, Adolescent, and Family Branch. We're very excited to be offering this clinical track for System of Care grantees. The purpose of the Clinical Learning Series is to identify and provide technical assistance around the latest innovations in child and adolescent clinical interventions. If there are clinical areas of interest you would like technical assistance on, please don't hesitate to let us know. Our goal is that the series will appeal to a broad audience, including youth, families, clinicians, and administrators, allowing all interested stakeholders in your community to gain access to the latest information on best practices in behavioral health care for children, adolescents, and young adults. Upcoming webinars in the clinical series include a discussion of new opportunities for partnerships between child welfare and systems of care, which will be presented by Claire Anderson of Chapin Hall at the University of Chicago on May 14th from 2 to 3:30 p.m. Eastern Time. With that brief overview on the Clinical Distance Learning Series, it's my pleasure to introduce today's talk on monitoring psychotropic medications in children and youth, presented by my colleague, Kamala Allen. Kamala is Vice President for Program Operations and Director of Child Health Quality at the Center for Healthcare Strategies. She will be discussing the role that psychotropic medications play in the treatment of children and youth with serious behavioral health needs and how systems of care can improve the quality of behavioral health care for this population. Office hours for this webinar will be held on April 20th at 2 p.m. Eastern Time, so please mark your calendars. Kamala?
Thank you, Diana. Hello, everyone. I'm very glad to have all of you on the line today. I'm looking forward to sharing a wealth of information with you, and then look forward to the subsequent office hours for any of you who want to talk a little bit more in depth about this topic. So what I would like to do is to start out just by finding out who is on the phone with us today and what role you play in the system of care in your community. So Colin has pulled up our first poll question. You'll see a couple of more of these over the course of the presentation, but if you could just take a moment. This just gives me a better sense of whom I'm talking to, so I appreciate that. Okay. All right. We'll give it another 30 seconds or so. All right. And I have my colleague here, Jessica Lipper, in the room with me, who's going to be supporting me during the webinar. I want folks to know that name as well, because she is part of our team here at the Center for Healthcare Strategies and works on our Psychotropic Medication Quality Improvement Collaborative and our other pieces of work related to the use of psychotropic medication, both in children in foster care and more broadly in the Medicaid population. Okay, Colin, if we could, in the poll, I think that we have a flavor for who's on the line with us today. So let me just start by moving to the next slide and telling you a little bit about the organization that we are from. The Center for Healthcare Strategies is one of the partners in the Technical Assistance Network. We are looking forward to a very long relationship through the TA network and opportunities to support systems of care and others who are working on behalf of children and youth with behavioral health needs. The Center for Healthcare Strategies, as you can see there, is a nonprofit health policy resource center. The center has been around since 1999, initially with funding from the Robert Wood Johnson Foundation. We have evolved from largely a grant-making organization to an organization that provides technical assistance. Our primary constituencies are state agencies. We also support federal agencies in the provision of technical assistance. We work with family and youth organizations and with various aspects of the delivery system. So, for example, managed care organization or other service entities. Next slide, please. What I'd like to do is just give you a quick overview of what I plan to share with you this afternoon. I want to start off with a little bit about why we're focusing on psychotropic medications. From there, I will move to an overview of behavioral health needs among children and youth in Medicaid, and then talk about use and expense of behavioral health services and psychotropic medications in that population. From that background, we'll move to defining oversight and monitoring, and then the role of the system of care. And I'm sure those of you on the line have thoughts about that, and we will solicit your input on that as well. And then we'll move to several key strategies that we've identified for an effective oversight and monitoring system based on work that we've done with both states and managed care organizations with the input of family and youth organizations over the last several years, and we will end with technical assistance resources. So, the issue. The issue is complex. I'm sure many of you know that from your work with children and youth. Psychotropic medications have been a source of increasing concern among state federal policymakers, providers, children and youth, family members, and those who work with them. There are many unknown consequences of the use of psychotropic medication on the developing brain, side effects on the metabolic functioning of children and youth, and obviously potential misuse in the case of a misdiagnosis. So there's ample reason for concern. The issue of appropriateness of use is also a complex one. There is no, let me say it this way, behavioral health needs are not like broken legs where there's a pretty clear set standard for how to treat that. And so individuals are unique, their needs are unique, the context within which they live are unique, and those things all influence the behavioral health needs and manifestations of a particular child, youth, and family. This next item, too many, too much, too young, it's a phrase that was coined several years ago by a group of Medicaid medical directors who realized that this issue of psychotropic medication use, and particularly the use of antipsychotic medications, was concerning. And what they did was identified a few parameters. A child, or in that case they were looking at children and adults, but in our context, a child receiving too many of these medications, receiving too high a dose of those medications, or a child who was perceived to be too young to be receiving whatever medication was being prescribed. And I also like to mention here that there's also I would say and any. So in some cases there's concern about any psychotropic medication being prescribed for an individual based on their needs. And we'll talk about trauma as being one of those manifestations a little bit later on. In the next set of bullets here, I've identified some populations that are of particular concern, either because of the unknown consequences of psychotropic medication use in that population, so that would certainly apply to very young children. Thankfully, when we look at data from the states, we don't see a large number of very young children who are receiving psychotropic medication. So again, the data, at least at this point, don't suggest that that is a large number of children, but certainly we want to make sure if any children of that young age are receiving those medications, that it is appropriate. Transition age youth, another population that, of concern. Those with substance use disorders or co-occurring mental health and substance use disorders, and children in foster care. Segueing to the next slide, children in foster care are a population that have been identified by the 3 federal agencies concerned with that population, both in terms of the Administration for Children, Youth, and Families, who oversees the state programs or the local programs of child welfare and specifically foster care, the Medicaid agency, or CMS, which is obviously overseeing the Medicaid programs across the states, and then lastly SAMHSA, which everyone on this call is certainly familiar with. Those 3 agencies within the Department of Health and Human Services issued a joint letter at the end of 2011 identifying the use of psychotropic medications in the foster care population as an area of particular concern. And some of you on the call may have actually participated in a 2012 summit in which the agencies brought together the child welfare, Medicaid, and behavioral health administrators or senior staff within each of the 50 states to try to develop plans to address this issue in their foster care programs nationally, which was a pretty landmark undertaking. So there you have a bit of the backdrop, and I want to shift gears a little bit and talk about what we now know about the needs of the population. So children and youth in Medicaid is where I'd like to step back to and provide a little bit of context. Next slide, please. Starting with the general population of children and youth, so not specifically those involved in the Medicaid program, here's some statistics, some estimates of mental health needs among that population. In that group, one estimate is that 20% have a DSM diagnosis or reported by their parents to have an emotional or mental health need. 11% diagnosed with a mental illness. It's understandable why that statistic would be a little bit lower. We don't have parental report as one of the sources for that one. And the last two suggest a little bit more about what the system is doing. So 2/3 of youth who have a condition are not identified and do not receive mental health services. That makes sense. Oftentimes, if there's no condition identified, we wouldn't expect for them to receive mental health services. And then finally, the last bullet has to do with the early onset of mental illness or substance use disorders, and that happening for half of individuals during adolescence. So we see why it's important for us to really be looking at the mental health needs of children and youth, and I know that that's preaching to the choir for this audience. Next slide, please. And so one of the things we would want to move from that general population is down to children involved in the Medicaid program. And some would say that if we have from 11 to 20% of the general child population who have a mental health or behavioral health need, we could understand why that need might be higher in the Medicaid population. And so there's certainly a number of reasons. 4 of them I've illustrated here. So low income, exposure to adverse childhood experiences, a lack of access to services and supports, particularly prevention and early intervention services. And we know that the context within which a child is living certainly has an impact on their behavioral health. And so inadequate access to mental health and substance use disorder services for parents and caregivers are just 4 of the reasons why we might expect that these estimates would be higher for children involved in the Medicaid population. Next slide, please. So now we've talked a little bit about need. I want to move to a little bit about service use. Next slide, please. The Center for Healthcare Strategies undertook actually a several-year analysis of Medicaid claims data, and that was released at the end of 2013. We refer to it as our Children's Faces, or Kids Faces project. And in that study, we looked at Medicaid claim data from the year 2005. We're actually in the process right now of conducting these analyses again using 2008 data, and we're in the process of planning for the next iteration of that using 2011 data. All that said, looking at the 2005 data here, when we look at the children in Medicaid who use behavioral health care, and by behavioral care, I mean either a behavioral health service, excluding psychotropic medications, and psychotropic medications themselves. So those 2 buckets together are what we referred to in this study as behavioral health care. And what we saw in that data was that just under 10% of children enrolled in Medicaid used behavioral health care, but those 10% of children accounted for nearly 40% of total Medicaid child expenditures. And what we've done here is broken out the percentage of children in these various categories. So 9.6% used behavioral health care, and again, that is services and psychotropic medications. When we looked at those who received behavioral health services, and those with or without psychotropic medications, it was just under 7%. And when we look at how many used psychotropic medication with or without a behavioral health service, it was just under 6%. And this last bullet is also somewhat concerning to us. It's a very, very small percentage of children covered by the Medicaid program in 2005 who received a behavioral health service received substance use disorder services. And in future analyses, we're going to be looking a little bit more in depth at that group of children. And the other thing I'd just like to highlight before we move from this slide is that these data are Medicaid only. So certainly we know that there are children who receive behavioral health services that are not paid for by the Medicaid program, but the Medicaid program is the largest payer, or the most, I don't want to say more significant, but they do incur the largest chunk of expenditures for behavioral health services for children involved in this program. Next slide, please. That slide was on use of services. This slide, very quickly, we're looking at the expenditures related to behavioral health services for children in the Medicaid program. And what you see here is that psychotropic medication in 2005 was the #3 highest expenditure service in the Medicaid program. That statistic, I want to say that for 2008, it has gone up to to the #2 slot, but we will have more information on that. We're refining the 2008 analysis as we speak. And just let me say one thing, I'm sorry, Jessica, before we move from that slide. I want to just kind of give a little bit of context for that one. That 43.8% of children who use behavioral health services and the psychotropic medications were 43.8% of those. That represented about 900,000 children, and that was up slightly from about 57,000 children in 2005. And yeah, I'm just looking at my note here. Yes, psychotropic meds did move up to the #2 slot in the 2008 analysis. Next slide, please. So, what does all this mean? There are many factors that contribute to the use of psychotropic medication. I said at the outset that this is a complex issue, and I wouldn't want anyone to leave this webinar and think that there is not a legitimate need for psychotropic medications within this population. I don't want to suggest or have it be misinterpreted that there isn't a need for these medications within the toolbox or within the continuum of services for children with behavioral health needs, because that's absolutely not what we're saying. What we're saying is that we want to make sure that for every child and youth that's served, that they receive the service and or support that is most appropriate to their need. And so that is the underlying theme for all of the work that we do around this issue and the technical assistance that we provide. So here's a list of factors, and again, I'm sure that there are other factors that you can identify based on your own work with the population. Inadequate screening and assessment, and in some cases misdiagnosis, can lead to the use of a psychotropic medication when it is not the most appropriate treatment for the presenting child or youth. Lack of access to other interventions, so psychosocial interventions, evidence-based practices, which we'll talk about a little bit later, an inadequate supply of child behavioral health specialists, and we certainly know that that's an issue in many of our rural areas of the country. The next bullet refers to the lack of coordination across providers and child-serving agencies. We know that within those agencies and across those providers, there's certainly an intent and a desire to have more coordinated processes, but that is certainly a work in process in most communities. And because you all are working, many of you are working in systems of care, we know that this is an issue that you are addressing in your day-to-day life, and that's critical for ensuring that children and youth receive the services and supports they need. Misaligned financial incentives. So I always refer to a conversation we had with Christopher Balanci, who I know, as many of you may know from earlier webinars in this series, who said that the financing incentives drive providers to prescribe rather than to assess and evaluate. And obviously the provider wants to make sure that that child and family that are in the room with them leave with their needs met. And so what we want to do is make sure that in the states that we work with, that the financial incentives are revisited and that they are revised in the most effective way that they can be to ensure that children and families get what they need, not just what's covered, quote unquote, under the Medicaid program. Folks, I'm sure, see the direct-to-consumer marketing by pharmaceutical companies. That's a very effective strategy. And so providers over the recent years have been seeing more and more folks coming into their offices asking for a particular medication based on the commercial that they saw. And so we know that we need to make sure that we have a system that is not driven by that. And then lastly here, limited clinical knowledge among child welfare caseworkers. For the most part, these individuals are not trained to make these kinds of clinical decisions. They're not trained to understand the side effects or the complexities of different complicated psychotropic medication regimens, and that says nothing about the caseworkers. We know that those are dedicated individuals who take their work very seriously and bring their all to the job every day. But now in states where the the consent for psychotropic medication is more often being vested with the caseworkers, we have to address that knowledge base. Next slide, please. Okay, so I'm going to stop talking for a moment, and I'm going to ask, thank you, Colin, if folks would take a moment to respond to yet another poll question. So this question here is in follow-up to what I just shared with you about the data that we have had access to related to psychotropic medication use through our Faces of Medicaid study. And I wanted to find out from you, how many of you actually have access to data about psychotropic medication use in the children and youth that you serve in your systems of care? So let's give this about a minute. And while we wait for those responses, I would just let folks know that if you do have an interest in some national data around the use of behavioral health services and expenditures for behavioral health services within the child Medicaid population, please go to our website, and I'll give you the link at the end of this presentation. And if you search for Faces of Medicaid, you will see our most recent study, and we would be happy to respond to questions if you have them once you have a chance to look at that. Okay, so this is good news. The majority of you, 62% versus just under 40%, do have access to information about psychotropic medication use within the population of children you serve. So that is absolutely a great thing, and I'm glad to hear that. Okay, so we've talked about the needs of the population. We now want to move into the kinds of strategies and tools that we might use to improve the use of psychotropic medication within this population based on our knowledge that there is a subset of children that do require this service. So first thing we want to do is we want to define our terms, and that's always important. I know many of you work collaboratively in your systems of care, and oftentimes our conversations and our progress towards goal can be thwarted because we are using the same terms and we mean very different things. So I wanted to just take a moment to share with you what we are using here at CHCS as the operational definitions of oversight and monitoring. So when I talk about oversight, what I really mean is an administrative process. And that process is to ensure that the prescribing is appropriate. And this can either be prospective or retrospective. This is an activity of the system, and it is focused on the prescribing patterns or practices of the providers. The second piece of this is monitoring, and when we're talking about monitoring, we're really talking about the child. And so this is the process by which this system ensures that the care that's delivered to the child is appropriate, and by default, it's retrospective. So we're looking back over time at prescribing for an individual child or group of children and monitoring both their progress, how much, are we seeing any decrease in medications over time as the child hopefully is improving, And the monitoring can be accomplished either through regular review of utilization reports or from other mechanisms. For children in foster care, I know in New Jersey they have a mechanism that is outside of their Medicaid claims system, and I'm sure many other states do as well, because there is a lag in Medicaid claims because that is a financial system as opposed to a clinical process. And so there may be other ways that folks can think about augmenting Medicaid claims to make sure that you're getting the data that you need to monitor how children are doing in their patterns of medication use and other service use for that matter over time. So those are what those terms mean in the context of the work that we're doing and when we use them. Next slide, please. Okay. So, systems of care, and I know, again, this is preaching to the choir, but what I wanted to do is just take a moment to call out some of the opportunities for systems of care within the context of oversight and monitoring of psychotropic medication use. So, one opportunity is certainly to change the culture of the mental health delivery system, to support children and youth as they recover, to support their resilience, and I should also say here in the context of their families, bringing in families, having them be at the table throughout this process is an important opportunity for systems of care. The second is changing the paradigm. So we have colleagues that we work with around this issue who are providers and are really trying to change the terminology from prescribers and wanting to not have those providers who prescribe defined by their prescribing behaviors. And so in the same way, we want to talk about changing the paradigm from medicating children to really meeting their needs. We want to think about medication being used when appropriate in the context of a potentially broader range of services and supports that are together designed to meet the needs of an individual child or youth in the context of their family or whatever other environment they might be in. The third bullet here is to supplement the formal treatment that is provided with community-based natural supports and resources. You all certainly know more than I about that. Ensure that families and youth are engaged in treatment decisions. Again, these are the hallmarks of systems of care. Increase awareness about alternatives to psychotropic medication. So in some cases, the challenge that a particular child or youth is facing may be so intense and so urgent that a medication may be the most appropriate immediate response. But in some cases, there may be alternatives that may be just as effective, and we want to make sure that there is some room in that system or in processes to ensure awareness of alternatives that may be viable for an individual child or youth. Awareness about side effects, and what I would actually say to augment that is the ability to engage in discussions in the last bullet with providers and others that are supporting that child and that family about the effectiveness of medications. If things are not improving, then there should be a revisiting, and that's whether it's with medication or a psychosocial intervention. And again, I'm sure you all could add to this list with your eyes closed. Next slide, please. And so I want to move now to some of the key strategies that we've identified in our work with states and managed care organizations, again, with input from children and with youth, actually, and family organizations. Here's an overview of those strategies. So number one is basically understanding the environment within which, the context within which services and supports are being delivered. We talked earlier about the needs of the population. Now we need to think about the needs of that population within the context that child and family live. And I think everyone knows that basically every state is an entity among itself. Every community is often an entity also among itself. And so we want to think about those unique characteristics that would define what may or may not be available in terms of services, supports, financing, other resources. The second strategy is related to the aggregation of data. We'll talk more about that. Engaging key stakeholders. You all, I know, do a lot of work with that, making sure you have the right people at the table and all the people who should be at the table. Improving access to evidence-based psychosocial interventions and understanding the role of trauma. Ensuring informed consent at the patient and provider level, and again, there's an asterisk next to informed consent when we talk about children and youth who are in the custody of the state. Investing in training and workforce development, education for the workforce, and then finally monitoring the impact of the changes that we make. So, next slide please. The first item there, understanding the payment and delivery system. It's very important to know how psychotropic medications are managed and paid for. That actually ties to several of the other strategies. One, for example, is engaging key stakeholders. So we want to make sure that the folks who are either managing or paying for those medications are at the table. We want to know how they're paid for so that we can ensure that the funding mechanisms are not creating those types of incentives that I mentioned earlier that are misaligned with our desire to provide the most appropriate care for the need of the child. Secondly, we think about the entities that are involved in the management or payment being at the table. I alluded to that, and certainly the Medicaid agency, which is typically the payer, the behavioral health agency, which may also be the payer in some instances. Managed care organizations, in an increasing number of states, managed care organizations are responsible for the organization and the delivery of those services through their provider networks. We want to make sure that we have those entities at the table. The capacity that different partners bring in terms of tools and perspectives is critical. So we know that in states with managed care organizations, they typically have more advanced or sophisticated data capacity than our state agencies or our local agencies, and we certainly would want to be able to leverage that. Again, the financial incentives and disincentives, being able to identify where we might have those levers for changing behavior at the provider level. Opportunities to engage providers. So, the other thing I would say based on the work that we've done with providers over the last several years is that they want to do the right thing, and they use the tools that they have available to them or the tools that they believe they have available to them. And so we want to make sure that that we understand what perspectives and tools they might have that we can leverage to improve the delivery of care to this population. And then finally, the clinical and or administrative expertise of the various partners, which we definitely are going to need as we both evaluate what our system looks like and what it does, both the things that we want it to do and those unintended consequences it may have. So that kind of is the whole ball of wax when we think about understanding that system. Next slide, please. The next strategy is the aggregation of data across systems. We need data from multiple systems to create a comprehensive picture, and that picture both of use and expense is very important if we're going to then refine or change our system. The first bullet here has to do with the definition or identification of key indicators. And we did some work with the 6 states that we worked with in our psychotropic medication QI collaborative around developing those and defining those indicators that certainly can be a resource to you. And I'll share that resource at the end of the presentation. The data from multiple systems allows us, as I suggested, to have a comprehensive picture of use and expense. It allows us to identify prescribing patterns that may be of concern. And it's always a good thing to have a comprehensive set of data because we may see that our problem is larger or smaller or exactly what we thought it was. But until we have data, we don't really know. So that's critical. The data allows us to understand the characteristics of the patterns of use. So the number of medications being used, the types of medications being used, the durations of use, all of those things are important to know because they have implications for the intended and unintended consequences of use on the child and youth. We want to be able to track quality and cost outcomes. We want to know what the changes we put in place are doing, what kind of impact they're having on quality and cost. And then finally, having a comprehensive set of data allows us to target the populations either of providers or children that we are going to be able to get the quote-unquote biggest bang for our buck with. So if we have a group of providers that are serving our children, we may want to target those providers who are serving the greatest number of children. If we've done some geo-mapping, we may see that there's a particular neighborhood or community where there are much higher rates of use than in another community, and we might want to target providers in that community. I talked earlier about children in particular high-risk groups, and so again, having data from multiple systems will allow us to have a better picture of whom those children might be. Next slide, please. And so on this slide, just wanted to share a couple of examples from states that we've worked with as it relates to this aggregation of data. In New Jersey, there is a health unit embedded within their child welfare system that works very closely with their Medicaid and behavioral health agency. A subset of the children who are served by that child welfare agency are also within the children's system of care in New Jersey, and one of the things that they are trying to do is actually bring their data together to understand how they can create a more comprehensive picture of the health-related needs and behavioral health-related needs of the children being served by both systems, who those common children are, and what kind of picture they can create of both their use of health and behavioral health services, including psychotropic medications. One of their quality improvement efforts was to add new fields to their SACWIS system, and that would include the documentation of their psychiatric evaluations that are completed for children and medication information. In Oregon, they have an integrated data system. They actually have coordinated care organizations in Oregon, if anyone is familiar with the healthcare reform efforts that have gone on there recently. And they have identified a set of metrics related to psychotropic medications using HEDIS, which is a data set that's used by managed care organizations, and there's a very uniform and distinct and descriptive set of specifications for what each of those measures are and how to collect and report that data. And they have created a data dashboard for their coordinated care organizations so that they can see both at the CCO level and the provider level what patterns of use look like for the children in their care, with a special focus in the work that we did with them on children involved in foster care. Next slide, please. And I alluded to this earlier, the engagement of key stakeholders. And in the context of our work, we really think about stakeholders as those who have particular roles within the healthcare delivery system. And so I've articulated that here as those who pay for, provide, regulate, receive, measure, monitor, interact with, or otherwise influence healthcare. And so you can see if you use the definition that I use, it's a very broad net that you're casting. The second bullet here is just, and I know we all know this, but I just felt like I wanted to just be very explicit about it, is that your key stakeholders have to be engaged if you're talking about systems change. And certainly with psychotropic medication and oversight, we are talking about system change. We're talking about changes that have to be wrought in major systems, so Medicaid, child welfare, behavioral health entities have to be at the table, they have to be engaged, they have to be willing to share their data. And in order to make that happen, you have to identify kind of those mutual goals around which everyone can come together, and certainly achieving better outcomes for children and youth with behavioral health needs would be one of those. I listed here in the third bullet just a few examples of internal and external stakeholders. I know many times when people think about stakeholders, they only think about the folks outside the four walls, and I just wanted to encourage folks to think about the folks that are inside your agencies as well, because you are going to need them to help you move the needle around these issues. And then lastly, just identifying a few types of engagement of those stakeholders. And that there's a continuum from just providing individuals with information and hoping they'll do something with it, proactively seeking their input, engaging them in the planning, monitoring, and or decision-making processes. And then if I were to maybe add another, it would actually be having some role in the oversight of the system on the other end. So next slide, please. And here's another example from the state of Texas has done quite a bit as it relates to the oversight and monitoring of psychotropic medications. Some of you may know that several years ago there were some concerns about the very high rates of psychotropic medication use in Texas, and particularly within their foster care system. And they've done quite a bit of work over the years to address that, including the engagement of folks from various agencies within state government and outside state government, including consumer organizations. They've also been very good at engaging their academic community, and the second bullet here refers to the clinical guidelines that they've identified. And I would also share that, while Texas did this work based on the needs that they identified within their state, what we refer to as the Texas algorithm has also been adopted by many states across the country. And so there's this desire to really make sure that even though some resources are developed in one state or community, that we help expose others to that, because there is certainly no need to recreate the wheel. Next slide, please. I mentioned earlier evidence-based practices and the fact that we don't want to talk about decreasing the inappropriate use of psychotropic medications outside the context of improving access to other psychosocial interventions that may be more appropriate to the need. And certainly evidence-based practices are important. What I've identified here are some pros related to evidence-based practice, and certainly, as I suggested, those can reduce reliance on psychotropic medications. And I've given a link to one of the SAMHSA resources around evidence-based practice. One con that we've identified, and by we I mean the community at large, not us here at CHCS, is that by nature evidence-based practices are defined for specific populations, and it doesn't work for everyone. And so one of the tools that's been developed is an approach called Managing and Adapting Practice, or MAP. And Bruce Torpeda and Eric DeLayden out in California have been working with many states and communities to use MAP, which allows you to basically match the different components of evidence-based practice to the needs of a particular child or group of children. And so there's a lot more information about that on the PracticeWise website, and it's definitely a resource that we try to expose as many folks to as possible. Next slide, please. Trauma. So one of the things that we want to make sure that folks understand as it relates to trauma in the context of psychotropic medication use is that there are particular manifestations of trauma that can be misdiagnosed, and for which psychotropic medications are then prescribed. And so we always want to put a spotlight on trauma. Certainly there's a trauma initiative being supported by SAMHSA. There's 3 rounds of trauma grants that have been awarded by the Administration for Children, Youth, and Families. And so at the federal level, again, there's a very clear understanding of the role of trauma in the context of behavioral health in children and youth, and a desire to increase an understanding of the various manifestations of trauma and the most appropriate response. So this statement is one that comes from the Child's Mind Institute. The link is there if you want to read that article. Next slide, please. Informed consent. So we think about making sure that there's informed consent when an individual goes in for a surgery. We want to make sure that they understand what the possible the things that might go wrong might be things, what they could expect in terms of recovery, things of that nature. And when we think about the use of psychotropic medication, it's no different. Certainly in the context of children who are in the home with a family or parents, that informed consent is a very straightforward proposal. You go in to see the provider, they tell you what the treatment is that they're prescribing, and they want to make sure that you understand the potential risk before treatment begins. That varies for populations who are in the custody of the state. So for children involved in foster care, there's typically a standard of reasonable care or I want to think of the term that we use, it's going to escape me at the moment, but basically any care that's beyond usual and customary. And psychotropic medication fall into that latter category. So the state has, in many instances, and this does vary across states depending on the Child Welfare Agency policies for that state or the law regarding consent in that state. There are many ways or various ways in which consent has to be sought. And so in some states, like in Illinois, there is the consenting entity is the Child Welfare Agency. There's one individual in the Child Welfare Agency who has to provide consent for psychotropic medication. We also think about what that time frame is for that consent. In some cases, depending on the age of the child, whether that assent is required or preferred. And certainly in some cases, and I know, again, Illinois is a state that comes to mind, where their quality improvement project part of it revolved around decreasing the number of instances when a child was prescribed a psychotropic medication without the consent of the state being secured. And so that's something that we certainly want to make sure takes place. And again, in some cases, it's the state that's providing that consent. In other cases, it's the biological family, even if the child is not in their physical custody. Okay. Workforce training and education. And so, there is a trend in terms of the needs going up and supply going down. We know that with the Affordable Care Act, we have, I believe it's 16 million additional individuals who will be relying on the Medicaid program, and we don't see a corresponding increase in the supply of providers to meet the need. And so that's certainly an issue that there's funding that's been designated to try to address workforce training and education. We know that the need for child and adolescent psychiatry professionals in particular is one that's of concern when we think about this, and we know that there is an increasing reliance on primary care providers to deliver behavioral health services, and so certainly that is another area around which training and education need to be directed. I know Jessica was sharing with me about a recent SAMHSA workforce development initiative. I'm sure there's more information to be found about that. If folks are interested, we can try to make sure we have that available for the office hours or send it out to folks who are on the call who may want more information about that. Next slide, please. So I'm going to stop talking again and ask if we can move to the poll question. So, I talked about a number of strategies over the last several minutes, and what I'd like for you to do is to think about the work that you're doing within your system of care and identify which of the following you see as your highest priority strategy for increasing the appropriate use of psych medication among children and youth that you're serving. So the first is, again, changing the culture of the mental health delivery system to support resilience and recovery, or changing the paradigm from medicating children and youth to meeting the needs of individual children and youth. The third is supplementing formal treatment with community-based and natural supports and resources. And then finally, ensuring that families and youth are engaged in treatment decisions. So we'll give another 30 seconds or so for folks to weigh in. And it looks like at the moment, about half of you identified changing the paradigm from medicating children and youth to meeting their individual needs. So thank you for your response to the poll. So going back to our presentation, the next question, I'm sorry, not the next question, is we wanted to end, we ready there? Yes, good. We wanted to, yes, thank you, to talk about all of the strategies that we've just kind of covered. Let's say you've done all that, then what? And I wanted to make sure that we ended the presentation really talking about the importance of monitoring the impact of the changes that you've made. So you'll recall on the previous slide, I talked about some resources that CHCS has developed in partnership with our 6-state collaborative. And those metrics, again, will be available on the website, and we'll provide the link to that. But you have to rely on the metrics that you identified at the beginning of your project to track your progress. So we want to talk about, in this one, kind of beginning with the end in mind. So when you're talking at the beginning of your planning process about what kinds of goals you have, you kind of have to, again, think about the end in mind, what you want to see achieved at the end of the project. And sometimes you won't see immediate progress. And so we here at CHCS do a lot of work on continuous quality improvement and plan, do, study, act cycles and things of that nature, where if we make changes and we don't see the types of impact on our goals that we had hoped to see, then we kind of go back to the drawing board. And I'm sure many of you do that within your own organizations and figure out, okay, what do we need to do differently? Is it that we don't have the data that we need to be able to see the impact on this particular indicator, or do we need to allow more time, or do we need to go back to the drawing board and identify another metric that's really going to get at that particular outcome? Secondly is sharing information with your key stakeholders. So obviously we want to have them engaged at the outset, but we don't want to just kind of leave them at the planning process and not carry them through. So we want to share information with them. One of the key roles that your stakeholders play once you've implemented your change is helping you determine whether you are having potentially unintended consequences. Each of those stakeholders has a different perspective on the issue, on the problem, has a different view from their perspective on the system, and you certainly want to have information from each of those perspectives. And so sharing information with them about what types of changes you're seeing or are not seeing will give them the opportunity to potentially augment the information that you have so that you have a more clear and comprehensive picture of what's happening or not happening. Identifying sustainable funding mechanisms. So this one is critical. We talked earlier about having a clear understanding of how psychotropic medications are paid for and delivered. Once you've kind of implemented your change strategies and you've created the different mechanisms or processes that you want to implement for oversight and monitoring, how do you make sure that those processes are sustained over time? If it's a position, if it's, you need more data, so you've hired a data analyst, for example. How are you going to sustain the funding to support that role, that critical role in your system? The other thing I would say as it relates to the funding is related to the access to non-pharmaceutical types of interventions, so those psychosocial services and supports. That mapping allows you to identify other funding sources that may increase access to non-Medicaid covered services and supports, and so certainly those are going to be very critical. And things like MAP, which we discussed a little bit. There's certainly some resources that would need to be brought to bear in order to implement some of those types of programs within your states and communities. Identifying areas for continued attention. So I mentioned this continuous quality improvement mentality that we want folks to have is that, let's say we hit our first set of goals. Now, what are our stretch goals? What's the next level of improvement that we can look to achieve? And then finally, having access to national and statewide resources. SAMHSA has certainly identified the use of psychotropic medications for all children and youth as a priority, wanting to make sure that there is information about how to appropriately, excuse me, think about and use those services for the population. And there are a number of collaborative opportunities. We are developing and are going to be supporting some virtual learning opportunities moving forward with SAMHSA support, excuse me, and you certainly would have access to those. So I think we move to resources. Jessica, would you speak to this one for me?
Yes,
thank you.
Sure. So on this slide, we are providing you with a selection of resources. On that first bullet, our own Center for Healthcare Strategies, that link takes you to the resources that have been developed as part of the Psychotropic Medication Quality Improvement Collaborative. Kamala mentioned a few of them, such as defining your metrics. There is a resource available that will share with you the metrics that the 6 states in the Quality Improvement Collaborative have used or are using. We've also provided you with the link to PracticeWise, as well as the National Registry of Evidence-Based Programs and Practices, which goes to what Kamala had mentioned about those non-pharmacologic interventions. And then we have some additional resources for you on child psychiatry access programs, as well as Texas's psychotropic medication utilization parameters for children and youth in foster care, which is used to some degree in several states throughout the country. And finally, SAMHSA's trauma and guidance for a trauma-informed approach. So we encourage you to take a look at those resources, to share them with your colleagues. And anything else?
No, I think that's it. So I think at this point, I know we are not going to take questions right now, but we would like for people to participate in the office hours next week on Monday afternoon. I know that there were questions raised about access to the presentation. That will be made available for download so that folks have access to that. And if there are specific questions that individuals have after they've visited the CHCS website, we would be happy, again, to entertain those. We would encourage you to participate in the office hours if you can, if your schedule will allow. The office hours are, I believe, on Monday, I want to say at 2 o'clock.
We are pulling it up.
Okay, thank you,
now.
Jessica. And so we would be happy to have folks participate. What I would love if folks could do is, if you have questions and plan to participate in the office hours, if you can email them to me at the email address that was identified on the previous slide. Jessica, could you go back one slide just so they have our email address? That would be great. Then that would be ideal, so that we can be prepared and make sure if there are things that we want to grab to bring with us to office hours so that we can refer to them in response to your question. We would certainly appreciate the heads up so that we can make sure we can be as helpful to you as possible. So I think that's it for us today, and thank you so much for your time and attention, and we look forward to opportunities to talk with you in the future.